So clinically, first you have to suspect any disease to diagnose it. If you have a good clinical suspicious, then only you can diagnose disease. So history taking and clinical examination is necessary for a good diagnosis. The dyspnea can be subacute. The dyspnea can be subacute in pneumonia. There will be history of fever. As we know that pneumonia is an infective condition, there will be history of fever, cough with expectorant, and there will be history of breathing difficulty. Fever, cough with sputum, and there will be history of dyspnea. The presentation of pneumonia is subacute. Subacute, it gradually progresses over a period of time. So patient of pneumonia will present to us with history of fever, cough with sputum, and history of dyspnea, and on examination you can get the findings of consolidation. What are the findings of consolidation? We will discuss it in examination section. Remember here that in consolidation we get a bronchial breath sound. We get a bronchial breath sound. What is bronchial breath sound? What are the other different types of bronchial sound? What are the other different types of breath sound? What are added sound? We all discuss it in examination section of respiratory system. If in tuberculosis we'll get a history of fever, cough with sputum, hemoptysis. We all have discussed this along with dyspnea. There will be also history of chronicity of the disease, like that of weight loss, night sweat, loss of appetite. All these things can present to us with tuberculosis. Interstitial lung disease. Interstitial lung disease, there will be history of dyspnea. That is the progressive dyspnea. History of dyspnea will be progress. It will progress over period of months to year. Dyspnea will progress over the period of months to year. And there will be history of dry cough. We have discussed this. There will be history of dry cough and there will be history of progressive dyspnea. And on examination, we will get a characteristic Velcro crabs. We have discussed what is Velcro crabs. Again, we will discuss it in examination section. Dyspnea in patient of metabolic acidosis. Dyspnea in patient of metabolic acidosis. What can cause metabolic acidosis? Chronic kidney disease, diabetic ketoacidosis can cause metabolic acidosis. So when there is metabolic acidosis in the patient, the lungs try to release the acid in the form of CO2. The lungs try to release the acid in the form of CO2. So how the lungs can release extra amount of CO2? By hyperventilating. So the respiratory rate increases in patient of metabolic acidosis and can cause breathing difficulty or dyspnea. This is not actual breathing difficulty. This oxygen saturation might be normal, but the patient is tachypneic. This is because of metabolic acidosis. The lung is compensating for the metabolic acidosis to cause respiratory alkalosis in patient of chronic kidney disease and diabetic ketoacidosis. In patient of chronic obstructive pulmonary disease, there is dyspnea. And this dyspnea is usually exertional dyspnea along with cough with sputum. As we have discussed that there is history of cough with sputum. In bronchiectasis there is large amount of cough. In emphysema there is usually lesser amount of cough, and there is dyspnea on exertion in patient of chronic obstructive pulmonary disease. On examination finding, you can get an hyperinflated lung field. We are not discussing in detail the examination finding of each disease. We'll discuss it in examination section, but there will be hyperinflation of lungs in patient of chronic obstructive pulmonary disease. Now let us discuss about wheeze. What is wheeze? Wheeze is a continuous high pitch musical quality sound. Continuous high pitch musical quality sound produced because of turbulent flow of air in the narrowed bronchus. When the bronchus become narrower, there is turbulent flow of air through this narrow bronchus, which produce a characteristic high pitched musical quality sound known as wheeze. So when we think of wheeze, we think of chronic obstructive pulmonary disease. When we think of wheeze, we think of asthma. Remember, wheeze can also occur in acute bronchitis. Or foreign body reaching the bronchus can also produce wheeze. Wheeze can also occur in acute bronchitis, asthma, COPD, or foreign body. Wheeze is usually expiratory. What I mean to say here is that normally wheeze occurs during the expiratory phase. As we know that respiration has two phases, inspiratory phase and expiratory phase. We get to hear wheeze mostly in the expiratory phase. Why we get to hear wheeze mostly in the expiratory phase? Because there is normal tendency of the bronchus to collapse during expiratory phase. In normal individual also, bronchus little bit constrict during expiratory phase because of negative intrathoracic pressure. So if the person is already having bronchoconstriction and super added to that, if the patient is expiring, there is super added bronchoconstriction, normal bronchoconstriction along with already bronchoconstricted lungs. So in expiratory phase, there is added bronchoconstriction. That is why wheeze is mostly produced in the expiratory phase. If wheeze is occurring during inspiration, we have to differentiate it from stridor. What is stridor? It is produced because of obstruction of the upper airway, like that of larynx and trachea. Wheeze is produced because of narrowing of the bronchus, small bronchus and medium-sized bronchus. But stridor is produced because of obstruction of the upper airway and trachea. Stridor is basically inspiratory. Wheeze is basically expiratory. Stridor is produced during inspiration. Wheeze is produced during expiration. Stridor is also high pitch. Wheeze is also high pitch. But stridor is because of obstruction of the upper airway, which is because of obstruction of the medium size, small size bronchus. Stridor can produce because of foreign body in the larynx, tumor in the larynx, trachea, or foreign body in the trachea. So if wheeze is present during an inspiratory phase, we have to differentiate it from stridor. If the wheeze is produced during exercise, if the wheeze, as I told you in cough, if cough is produced during exercise, it suggests COPD. And if the cough is produced after exercise or during resting period or recovery period, it suggests asthma. As I told you, during exercise, there is increase in sympathetic tone, which causes bronchodilation during exercise. So asthma attack usually doesn't occur during exercise because of increased sympathetic tone. So in asthma, there is bronchoconstriction. During exercise, there is increased sympathetic tone, which is causing bronchodilation. So there is no attack of asthma during exercise. But after exercise, when the person is resting, just after exercise, during recovery period, asthma can develop because of exercise. But exercise-induced asthma usually occurs after exercise, not during the exercise. But COPD patient will usually have wheeze during the exercise. So this is differentiating feature. So now let us discuss about chest pain. Wide pathology can cause chest pain, starting from the cardiac pathology like that of myocardial infarction. The respiratory pathology can cause chest pain, musculoskeletal chest pain can be present, or the gastroesophageal disease can also cause chest pain. So when we think of chest pain, we have to divide it into various systems like that of cardiac system, respiratory system, musculoskeletal system, and gastroesophageal system. Anything can produce chest pain. So it is important to take the history properly to differentiate between various systems. So what are the respiratory causes? We will not discuss the cardiac cause of chest pain here. We will discuss in cardiology section, but we will discuss the characteristic feature for how to differentiate the respiratory cause of chest pain from other causes. So as I told you that the respiratory chest pain is usually the pleuritic chest pain. And what is the characteristic of the pleuritic chest pain? It is sharp pain. It worsen. It worsen on deep breath or coughing, and it is usually localized to a particular area. It is usually localized to a particular area. So the characteristic of the pleuritic chest pain because of respiratory cause, the pain is usually sharp shooting pain. It is localized to the diseased area or the affected area, and it gets aggravated on deep breath or on coughing. But pulmonary embolism, as I told you, pulmonary embolism can produce angina like chest pain or cardiac like chest pain. So it is very difficult to differentiate pulmonary embolism from myocardial infarction. But in pulmonary embolism, always remember that there will be a precipitating factor present most of the time, like that of deep vein thrombosis, malignancy, recent surgery, which will help us suspect pulmonary embolism in the patient. Patient of herpes zoster. Patient of herpes zoster will complain of severe pain in the chest and burning sensation. And if you do not undress the patient, you will miss this diagnosis. There will be formation of multiple vesicular lesion over the one side of the chest. The patient may complain of chest pain and burning sensation. And if you do not undress the patient to see this vesicular rash present on a particular dermatome on the chest, you will miss diagnosis of herpes zoster in the patient complaining of chest pain. Sometimes there is costochondritis, costochondritis with swelling of the costochondral junction, along with pain and swelling of the costochondral junction known as costochondritis or TG syndrome. It is a rare disease causing swelling of this is musculoskeletal cause of chest pain. There is swelling and tenderness of the costochondral junction known as TG syndrome. Bornholm disease. It is because of Kawasaki B virus infection. There is inflammation of the intercostal muscle. So remember, chest pain is not always because of myocardial infarction, not always because of pleuritic chest pain. Musculoskeletal cause can also cause chest pain, like that of costochondritis, like that of Bornholm disease. It is usually rare, but it is self-limiting condition and usually subside by its own or use of analgesics. Gastroesophageal reflux disorder, GERD. Gastroesophageal reflux disorder can cause burning chest pain, retro retroesternal retroesternal pain. But there will be associated symptom of dyspepsia, nausea, vomiting, epigastric discomfort, chest discomfort, or burning retroesternal pain. Sometimes the myocardial infarction patient may also present to us with same symptoms, but if you have clinical suspicions that this is not because of GERD, this is because of myocardial infarction, always do an ECG to rule out myocardial infarction if the patient is complaining of burning retroesternal pain. especially if the patient is having comorbidity like that of diabetes, hypertension, age. If this older age patient complaining of diabetes, hypertension, especially female patient complaining of burning retrosternal pain, always do an ECG to rule out myocardial infarction. What are the other clinical feature in a respiratory system for which patient present to us or associated symptoms along with fever, cough, hemoptysis, breathing difficulty, chest pain, wheeze? What are the other symptoms in respiratory system? Rigor. Rigor can present to us in respiratory system disease in sepsis associated with pneumonia, in sepsis associated with pneumonia. Rigor can also present to us with acute pyelonephritis. In patient of acute pyelonephritis, rigor is present. In respiratory cause, sepsis associated with pneumonia can produce rigor. Night sweat. As we all know, TB is known to cause night sweat. TB is known to cause night sweat in respiratory disease. But we have to also rule out lymphoma. Lymphoma if patient is complaining of night sweat. Weight loss, chronic disease like tuberculosis, lung cancer, bronchiectasis, and COPD, all this can cause weight loss. What is the significance of past history? What is the significance of past history? What is the significance of past history? Is there any history of asthma? Is there any history of measles, pneumonia, tuberculosis in the past? All this can cause bronchiectasis. So if you are suspecting bronchiectasis and you are not able to find the cause of the bronchiectasis, you can take the history of measles. Measles is known to cause bronchiectasis. Recurrent pneumonia is known to cause bronchiectasis. Tuberculosis is known to cause bronchiectasis. Connective tissue disorder can cause respiratory problems. Connective tissue disorder can cause respiratory pathology like that of interstitial lung disease, pleural effusion, malignancy. As I told you, malignancy can cause thromboembolism and pulmonary embolism. Drug history. What are the drug history important in respiratory medicine? Whether the person is taking any multi-dose inhaler, nebulizer, bronchodilator, then we must suspect the patient is a case of either COPD or the patient is a case of either asthma or COPD. Sometimes the patient may present to us with acute attack of asthma. We must take the history of certain drug which has precipitated the acute attack of asthma. Suppose the patient has went to a ophthalmologist. Ophthalmology has prescribed him beta blocker for some reason. The topical beta blocker dropped for some reason. And this beta blocker has precipitated asthma in the patient because of bronchoconstriction. So history of any beta blocker should be taken. If the patient is taking an AC inhibitor, as we know that AC inhibitor can produce cough, it's dry cough. So history of any intake of AC inhibitor, Ramipril, is important. Estrogen can cause thromboembolism. Estrogen can cause thromboembolism. Antimetabolites like bleomycin and methotrexate. Antimetabolites like bleomycin and methotrexate can cause fibrosis or can cause pulmonary fibrosis. Family history of tuberculosis, family history of cystic fibrosis is important. Social history, what is important in social history is the history of smoking. What is one pack year of smoking? What is one pack year of smoking? If the person is smoking 20 cigarettes, if the person is smoking 20 cigarettes for 1 year, it is known as one pack year. It's known as one pack year. So let's suppose if the person is So let's suppose if the person is smoking 10 cigarette, person is smoking 10 cigarette for 20 years, 10 cigarette for 20 years, then how much pack year? This is the formula to calculate the pack year. If the person is smoking 10 cigarette for 20 years, so what is the pack year? So what is the formula? Number of cigarette into number of years divide by 20. So this is the formula to calculate pack year. So if the person is smoking 10 cigarette for 20 years, 10 cigarette for 20 years, so this is the formula 10 into 20 divided by 20. So it is 10 pack year. It is 10 pack year. Occupational history is most important. Occupational history is most important in respiratory medicine. Wide variety of occupation can cause respiratory disease like that of fibrosis, like that of bronchiectasis, like that of pneumoconiosis, asbestosis, coal miner, silicosis. Everything history of occupation is important in respiratory medicine. So there is wide list of occupational disease which we will discuss later. So remember that occupational history is important.